Hello, everyone, and welcome to today's webinar sponsored by ComForCare. I've placed a message in the chat box if you'd like to review that throughout the webinar, but wanted to cover a few housekeeping items. The handouts were sent a short time ago. Please check your junk folder if you have not seen those handouts. CEs will be given to all that attend the entire session. There will be an evaluation that comes up at the end of the webinar. Please complete the evaluation. If time permits, we will take questions at the end. Please place those questions in the Q&A. I want to thank our presenters today, Tiffany Robinson and Colleen Toby. Welcome, Tiffany and Colleen.
Thank you so much. Hello, good afternoon to everyone. My name is Tiffany Robinson. I'm honored to be with you here today. I've worked for ComForCare for the past 20 years. I hold a bachelor's degree in social work from Oakland University, located in Rochester Hills, Michigan, and a certificate in instructional design from the University of Maryland. At ComForCare, I work as a training specialist. I specifically work with onboarding our new offices and helping them facilitate their training programs.
Thank you, Tiffany. And my name is Colleen Toby. I'm the Vice President of Clinical Services for Pathway Health. And I'm so honored that to be working with Tiffany again on this very informational webinar sponsored by ComForCare. Today's topic is infection control for high-risk older adult population. Within our overall objectives as we go through this, we can see here that you've already seen our pictures. We can see here that we've got course objectives, and we're going to describe the importance of advanced infection control through the older adult population across the care continuum. When we look at care continuums, and as I want to focus on this, there's a difference between someone being admitted to a nursing home or someone that's living independently within the community receiving home care services, or someone's living in the assisted living. We'll identify some key best practices to reduce the infection transmission, including detections and strategies and a quick outbreak response. What is the role of antimicrobial stewardship? And this is not probably a new topic, but it still is extremely important. And then at the end, we'll talk about practical strategies to support staff through the implementation of these specific practices. Now, within this, the course description, which you have all received, is going to look at some of these best practices and antimicrobial stewardship based on our operational strategies and our course objectives. But the first thing I want you to take a look at is where we are right now. And this was taken and put on this about a week and a half ago, this slide. But you can see that acute respiratory illnesses are tracked very closely here in the United States. And we can understand the importance of advanced infection control practices. These strategies are really designed for not only the line staff, but leadership practices to prevent infections, monitor infections, and reduce the spread. Just because you're a state that's in a very high activity right now for respiratory illnesses does not mean that you're a state that does not have good infection prevention tactics or tracking mechanisms. It's just the way it is at this point in time. With measuring, we have to incorporate not only looking at antimicrobial stewardship, but we need to incorporate things such as making sure we have identified trends within the community and then putting those best practice standards forward. In addition to this, I want to talk about some very specific community-acquired disease processes. Now, when we talk, again, you know this, a community-acquired pneumonia is a high-risk disease process. There's viral respiratory infections. We do have catheter-associated urinary tract infections, community-acquired bloodstream infections, and then we've got the norogastrointestinal gastrointestinal infection. But the one that we need to focus on is really the community-acquired pneumonia. This is the leading cause of hospitalizations in adults that are over the age of 65. They have a higher severity, longer hospitalization stays, higher mortality. And as you age, you know that you have a decreased response, immune response with aging. And then, of course, those multiple chronic conditions. And the bottom line is community-acquired pneumonia is a dominant in that older adult within our communities. This is a nice breakdown of the age of the hospitalization risk factors that go along with community-acquired pneumonia. And you can see it's after the age of 75, it's very high. And many times the death rate or morbidity and mortality increases with age. In addition to this, that broad spectrum of community-acquired infections, as we can take a look at this, is that respiratory tract, and we've done a lot of identification and tracking and trending, monitoring these at our local state health departments. But once again, it is so imperative that we quickly identify what type of respiratory tract infection, whether it be in the community, the nursing home, or your assisted living, and then have a good response to this. The gastrointestinal infections, just as I stated, that is often norovirus or having salmonella, which again is one of those foodborne illnesses, and then skin, soft tissue, MRSA, urinary tract infection. But let's talk first about the advanced infection control for the community-acquired infections. One thing that happens here is those infections spread fast. As we identified this within our older adults, we can look at these infections and how they're so dangerous. I mentioned that the symptoms are often subtle and atypical in our older adults. And that's something when you're looking at these older adults that you're caring for, or you're doing your home care visits, or they're in the assisted living, these symptoms are atypical. They could be something like, I don't feel very well today, or I'm just tired. But here's what happens. These symptoms escalate at a proportion that's greater than the individuals that are younger. That early detection and rapid response of these respiratory illnesses, and then identifying clusters of this type of illness and immediately tracking or notifying the health department. Based on the state you're in, some health departments would like every single infection that you've identified, like RSV reported or influenza, and some don't. But again, these escalation of these types of illnesses need to be monitored and tracked carefully. As we know, vaccinations are the wonderful tool with this, and it's the primary prevention tool with advanced infection control. But again, you look at your engineering controls, improving that air quality, and then instructing people that if there is a high risk of infection in the community and you have something even in your assisted living building, to ensure that we don't congregate. Within your organization, you have policy and procedures related to advanced infection control that'll help for screening, triage, and separation of symptomatic individuals. Clear outbreak response plans for your group homes, even homeless shelters, have to be put in place. And those enhanced personal protective measures with broader uses of masks, reinforcing respiratory hygiene, and then last but not least, but one of the things that's so important is really taking a look at hand hygiene. Within our community, we know that urinary tract infections are probably one of the most prevalent types of infection that results in a visit to the emergency room. They're extremely common in that older adult. Within this, you could identify this based on fatigue, confusion, behavioral changes, but with advanced infection control, we want to emphasize other practices other than just giving antibiotics. And antibiotics can be extremely effective. We know that there are place and time for this, but with advanced infection control programs, and I'll go into this in more detail, we need to emphasize things like hydration, early symptomatic recognition of urinary tract infections, simple steps to prevent a major crisis. And it seems very simple. Let's increase our fluid intake. But as you work with older adults that may or may not be something at the top of their list, because with those types of infections, you can identify that they may or may not like to have an increase in a fluid intake because of other comorbidities that they have. So with this, we look at why does it really matter? And yes, we have a large number of community-acquired urinary tract infections. But another thing, if we look at the age-related changes, it is important because when you have people residing in the assisted living or they're in your group home, your home care agency, rehospitalization and hospital and over for a urinary tract infection can be detrimental to their well-being of that individual. As those age-related changes begin, we have to understand that there's a physiological change with the aging process, especially when it comes to increased incomplete bladder emptying. How are you assessing that individual if you're admitting them to your home care agency or if they're in your nursing home? Anytime we have infections, there's a greater likelihood of delirium. And what happens with delirium and confusion? Falls. Falls most often will end up as potential fractures, and fractures may take that person out of their community-based service or their community-based home, and they will have increased risk of hospitalization and then possibly nursing home admissions. So as we identify, even though it is very common in older adults, we have to understand that problem that we have looking at older adults. Oftentimes, as medical professionals and as nursing individuals, we don't necessarily understand what is different between individuals that are 50 years old or 30 years old, and we have those individuals that are over the age of 65. But as I mentioned, that immune response is so important to understand. We do not have the effective ability to fight these organisms because we have a decreased immune response. Just as our skin begins to dry and wrinkle and we have the ability to turn over our cells and our skin decreases, you also have a decreased number of T cells to fight that type of infection. When we have that type of infection, we're looking at that incomplete bladder emptying, and a lot of that could be related to medications, chronic conditions, and then there's hygiene challenges. So when you have individuals living in a community-based service, it's your home care agency, are they able to have showers? Are they able to perform proper hygiene? And then last but not least, what medications are they on? When we look at all of these different types of infections and the risk of infection, we want to think of that advanced infection control practice. But something very common and very simple to do is look at their medications. You're thinking about medications that can decrease the ability to cough, decrease the ability to empty your bladder, and cause other types of problems. So look at this as far as an anticholinergic, and that's one of the most common. Some of the anticholinergics and antidepressant medications can cause problems. Antipsychotics, opioids, once again, they have a response to slow that activity and slows that smooth muscle response. They have, especially in older adults, they're extremely sensitive to this. Parkinson's disease medications, sedatives, and analytics. When you're admitting a client or looking at that client in a home-based service, or you're admitting them to a nursing home, you need to take a good look at medications. One, look and say, is this medication pose a risk to the health and well-being of this individual? Would this medication or using this medication, such as opioid pain medications, put them at risk for a community-acquired infection? Always look at medications. As I state, it's one of the easiest steps we can take. And by doing this, we also want to understand that immunosensus and what's driving some of this aging. Infection control in this population of the older adult is it needs to be looked at differently than when we see our younger individuals. This immunosensus really slows the degradation of the immune function. I mentioned that T cell fighting was gone, that ability, but it makes that older people more likely to be killed by infections or increased morbidity and mortality related to things such as influenza, urinary tract infection. They have that chronic inflammation with immunosensus as they age. There's a modulating effect related to this, and there's deficiencies between the dysfunctional immunity in the elderly and that immunosensus related to the immune system. Now, with that immunosensus and that immune response to infections, it's one other thing to make sure that we understand the importance of a good diet, making sure that this aging population, we understand the effects of malnutrition, and you don't have to be underweight to be malnourished. It just could be that lack of nutrients and deficiencies related to this, especially things that are so essential to our making sure that we maintain our immune response, such as vitamin A, vitamin C, your B vitamins, your folic acid, iron. So nutrition and infection. If you have good nutritional status, you have that decreased risk for infection and that immunosensus and of course that immune response. Now, I'm going to also bring up one other thing that we need to look at as when we're looking at the overall way to prevent some types of infections. I mentioned inflammation, and my favorite food group is probably sugar. But as we age, sugar causes problems, and it actually causes that inflammation. When we have that inflammation, we are more susceptible to infections. This includes our white blood cells that it weakens our immune system. It causes inflammation. It elevates our blood sugar. And if you do have diabetes, it just causes additional problems. So when you're talking to your individuals and when you're probably giving that once a month talk in your assisted living on some good health practices, think about this and explain that your inflammation affects your immunity. And some of those things, research definitely shows that you are more responsive to end up with respiratory tract infections, influenza, pneumonia, urinary tract infections, and then, of course, skin infections. We have to maintain good health to prevent infections. Processed foods, well, if we have something simple, and when I look at things that are very simple, when I talk about recurrent urinary tract infections, when I say, it would be a good idea that you reduce your sugar intake, and that doesn't go well. But with processed foods, bacteria, E. coli like sugar, and sugar spills into the urine, and urinary tract infections. People that are very vulnerable will end up with more urinary tract infections, and it becomes more pronounced in older adults. That high sugar diet is not what I would call, it's imperative that we look at this as we're looking at advanced types of infection control practices to keep our individuals healthy. So thinking of this, that weakened immune system can be influenced by a high sugar diet. It reduces neutrophil activity, increases systemic inflammation. And if any of you have done some research on diet and inflammation, you have a good understanding of how important it is to keep inflammation at bay. In addition to this, it slows the body's ability to fight off bacterial growth. So simply talking about diet and nutrition in our older adult communities could be one way to prevent recurrent infections, respiratory infections, that risk of RSV or influenza. The last thing is that with health is processed foods are high in sodium. Anyone have that favorite food of cheese and potato chips or all of that wonderful food. But when foods are high in sodium, they're low in water content. So providing that older adult with good fluids that have additional electrolytes will help reduce that potential of an infectious process. Anytime that when we have dehydration, it concentrates urine, it increases that likelihood of bacterial colonization, and elderly individuals already have a reduced thirst. But processed foods makes dehydration even more common. And because of this, and because what I'm stressing is healthy diet equals that healthy immune system. Healthy immune systems will help the older adult manage stress. It'll help you manage stress. It'll help with sleep. It keeps our level of blood sugars at a target range. And by encouraging good diet and good nutrition choices, such as eating fruit or vegetables, more than likely you'll see an overall decline in the number of community-acquired infections if you can go ahead and stress again the importance of this. With our gut and, of course, urinary microbe, we want to ensure that our intestinal tract and that permeability allows bacteria to translocate. You can identify that commonly there are yeast infections that can irritate the urinary tract, alter vaginal flora, and then create that susceptibility. Monitoring, making sure we do education for that older adult, and making sure that we provide the adequate hydration, adequate toileting, recognizing and early recognition, medication reviews, identifying and managing incontinence safely, reducing processed sugar, increasing hydration, and then improving fiber intake. You can do this, especially by a very low-cost strategy. It doesn't cost that individual client in the community. If they're living in nursing homes, these are very basic things, but they're high level, and prevention is truly the first step in infectious disease reduction. Now, I've spoken a little bit about community-acquired infections, the importance of diet, the importance of hydration routines, and decreasing, number one, of course, community-acquired respiratory infections. But I want to talk now more about RSV. RSV has come to the forefront, and we know that we're encouraging individuals to be vaccinated for RSV. RSV in its entirety has a high mortality rate. And with community-acquired RSV, we anticipate about 26.8%. This is the newest data. The mortality rate for individuals over the age 60. They're estimating about 740,000 hospitalizations. The 2025-2026 statistics are not out, but individuals in your communities that have chronic diseases and chronic conditions are more at risk for hospitalization. The other types of risk factors that they have with those chronic conditions is the chronic obstructive pulmonary disease. A lot of individuals have problems with respiratory function, cancer, diabetes, lung disease, and smoking kind of go hand in hand there. But looking at those medical conditions, when you admit an older adult to your community, you should be looking at their comorbidities. Is this person at risk for respiratory illness? What types of interventions are we going to put in place to prevent the transmission? Is this older adult, when we have a community outbreak, should we look to make sure we're keeping that individual with these multiple comorbidities safe? And once again, there's a lot of different organisms that are factors related to that community-acquired pneumonia and RSV. And these causal factors include things such as bacteria, your fungus, your fungi, and then of course our favorite Streptococcus pneumoniae. These are common. They are the ones that are researched, but one of these things that happen is, I mentioned, they have a real difficult time as we look at these symptoms. So the symptoms may not be very apparent, but they can go ahead and have a cough without any sputum production. They could have some shortness of breath. Most often they'll have a low-grade fever. If they're having a low-grade fever and chills and cough, they're probably going to be admitted to the hospital. So with your advanced infection control practices, you're looking at vaccinations, quickly identifying if you have one case of respiratory illness in your building, consider that a point in time to make sure that you isolate and use good infection prevention interventions to ensure that the spread of this virus or this bacteria is not throughout your whole facility. There is a definite research, and I even had a physician state early this winter, there was an outbreak of RSV in a facility. And the director of nursing was just at her wit's end. She goes, "What are we going to do?" And you know what was said? "I thought this was a good idea. Are they brushing their teeth?" Now, vaccinations are really good, but when we're thinking about community-acquired pneumonia prevention, something that we can teach our older adult is simply brushing their teeth. As people age, they have more dental plaque, more gum disease, more dry mouth, not drinking enough fluid, and the plaque is not just plain dirty. It contains a high level of dense biofilm. And within this, it'll contain things like Streptococcus aureus, gram-negative rods, and anaerobes. All of these, if they get in the wrong place, such as our lungs, they're going to be a problem. And if we can keep that risk factor at least under by doing good dental health, we may be able to prevent a hospitalization for that older adult. Simple things, if they do wear dentures overnight, you've got to make sure that they clean their dentures, make sure they remove their dentures. Are your clients having routine dental and oral care done at a dentist or a dental hygienist coming into your building? Do people actually brush their teeth that are part of your population? Are we stressing the importance of oral care? That is something that you would want to look at as preventive measures along with early identification, education, and vaccinations. With strong community partnerships and building those partnerships within our advanced infection control, we want to look at what we can do, especially when we're talking about community-acquired pneumonia. Those partnerships could be with our pharmacies. They can be with our primary care clinics. We want to make vaccinations easy and convenient. Maybe you want to do an outing, or maybe you're going to have the pharmacy come in and do vaccination day. By doing this and using senior centers, even faith-based communities or trusted spaces for outreach, we can actually increase the number of individuals of those older adults that will take those vaccinations. Things such as our community centers, our home health agencies, outreach for our homebound and mobility limited older adults, and then having a lot of those multiple points across the care continuum. In addition to that, we have to make this so they have the ability to get there. Evenings and weekends are probably the best time for family members to bring their loved one in to receive a vaccination. Track this closely, bundle opportunities, implement reminders, looking at that agency and making sure we can even transport those older adults. So can they transport? Do we have the vaccination information in different languages? Can we address their fears? Because if they're watching TV, they probably got some type of information that might not be correct related to vaccinations or what type of vaccination even to have. Pneumococcal, there's changes per CDC schedule, looking at that annual flu shot, so important. It's not only important for the older adult, it's important for healthcare workers or people that are working closely with the older adult. RSV vaccinations for that are eligible. And then, of course, we have our COVID vaccination and boosters. So there is information out there. The CDC has provided that. Your state has that opportunity to provide that information. And you, as a healthcare provider or servicing the older adults, should also provide that information. Again, there are going to be individuals that say, I'm not going to take the vaccination, and that's fine. But look at the strategies for that advanced infection control. Always think prevention. Medications, what are we doing? How is their diet? What can we do for that older adult to prevent that hospitalization and keep them healthy? With the community of older adults, be understanding. And when you've got your people with home care, they could be having limited access to dental services and then reduced ability to perform oral care. When I'm looking at some of these, it seems that with all the devices that we have, it would be so easy to make sure that they were able to perform oral care with these electric toothbrushes, making sure we have not sugary drinks, but something that tastes good that will actually enhance their ability to maintain electrolyte balances. If you're out there, there are many, many, many products that the older adult would benefit for, especially to decrease the risk of dehydration and that chronic disease burden. Another thing that often happens is they don't necessarily understand the medications, but even the over-counter medications, when you have community acquired diseases and people you're serving in the community that are older adults, please make sure you look at all medications, including the bunch in those huge packages of over-the-counter, because I know we might feel that over-the-counter medications are just real safe, but they not necessarily are. And when we look at that, we can devise an overall plan to promote health. As I said, anytime we're looking for preventive measures, first of all, watch for community-acquired pneumonia. Watch what's going on in your community. Go to the website and check every week or twice a week to see if you're seeing an increase in the number of maybe pneumonia or influenza or RSV in your community. Identify that population. So who are your people that have been vaccinated? Are we having any subtle types of changes in condition? With community-acquired pneumonia, they may not be typical. They could have a little cough or not feel good or didn't eat one day, and all of a sudden you're going to be treating an outbreak in your building related to RSV. And it does not take long. It's like putting a match to dry tinder in a forest. It goes that fast. But look again, reduce that risk by early identification, identifying people that are high risk, even for aspiration, and then making sure we have good systems in place to address these community-acquired pneumonias. Well, the next one I'm going to talk about is one that none of us really, this is a very common type of infection, but it's one that probably even you've experienced at some time in your life. Norovirus. We used to call norovirus the flu, and we know we've changed that now. Norovirus is gastrointestinal, and norovirus is the most common cause of gastrointestinal infections in the United States. It causes between 19 and 21 million, that's estimated illnesses a year, according to the CDC. In addition to this, it contributes to about 71,000 hospitalizations. Now, if you've ever had kids in school, it seems like they would have norovirus right after their yearly Christmas program. Everybody would be sick in school. But in addition to this, they're estimating, and this is a low estimate, they're having at least, I said, 71,000 hospitalizations, and this goes up with age. There's at least 1,000 deaths every year related to norovirus. So it's not the one as significant as community-acquired pneumonia. However, it can cause a lot of problems in your community. And it does cause a lot of problems in your community. A couple things and risk factors, once again, is that weakened immune system. Norovirus, you have to watch that very closely because I have seen this go through assisted living facilities and nursing homes over and over again, and we don't look at the symptoms. Okay, we're not watching for it. You need to look at what's happening in your community and the community is setting, and then looking for those individuals that have a weakened immune system that might have, they're living in really close contact, a lot of community dining or shared spaces. And of course, nursing homes and assisted livings are known for that shared space and how it spreads. It's difficult to ensure that it doesn't spread, but it spreads with astonishing ease. They are at high risk. They're looking through the ability to say, oh, I've just got the stomach flu. But no, it's more than just the stomach flu. It could keep people in bed 3 or 4 days. Body aches, fever, diarrhea, nausea, vomiting. And then not only are your staff caring for these individuals, eventually your staff is going to have it. Or maybe your staff brought it in and didn't realize that they were ill with norovirus. Now, the spread is something else, and there is significance related to the spread. The spread is person to person, one. Second, contaminated surfaces. Are you cleaning your food prep surfaces? When you have people living in the community, I know that we are going as community health nurse or into the apartments, but they're not necessarily as clean or using the types of surface cleaners that we would like. Food is prepared by an infected person. I've had this happen. Someone's infected in the kitchen or in there, and they did not know that. And then aerosol particles. And I'm going to talk about some of those norovirus, but it spreads primarily through person-to-person contact, but it will stay on surfaces, and it can be aerosol. That means when I'm talking, if I'm talking to you and I have norovirus, there's got to be some little particles coming out of your mouth or my mouth. I could actually infect somebody with norovirus unintentionally. Well, when we look at this is some of the risk with this, and you're probably very well aware of this, but it stays on hard surfaces for up to 2 weeks. Okay, so after Mrs. P in apartment 220 had norovirus, did we make sure that the surfaces were cleaned with some type of chemical that would kill that norovirus, or did we not? The soft surfaces for several days to a week, is that the beds? Linen. Does our staff making sure that in an individual that's had norovirus that they're handling things correctly? Are they or are they not? I'm going to request that when my staff was caring for people with norovirus, one, I didn't want them sick. Second, they wore a mask. Because of that aerosol type of particles that is possibly related to the spread, you want to make sure that we have good food safety controls and then avoid serving buffets during an outbreak. That's just common sense. I don't see communities doing that. But again, are we training them and teaching them on hard surfaces and how to clean them? Are we using something as simple as household bleach because normal, and then are we ensuring that they're using normal hand washing facilities and masking? So the last topic of today that I'm going to go through before we turn it over to Tiffany is on antibiotic stewardship. This is not something that has changed. We still need to keep the the ideal that antibiotic stewardship is extremely important. But once again, we have a population of older adults that when they go to the doctor, they do expect something. So antibiotics are only when they are clearly needed. With that, when you look at some of the things what we use our clinical judgment on, antibiotics, it's very important in adults living in the older adults living in the community. Many people who are not in nursing homes but receive primary care through clinics, home care, and senior housing. This group that is in the community is at high risk of over antibiotic use more than the individuals living in a nursing home. This high risk group, the antibiotics will definitely, they will sometimes be used for asymptomatic bacteremia, non-specific symptoms, or chronic urinary tract infections. And sometimes chronic urinary tract infections, if they're not symptomatic, it is something that they would not treat. As I stated, the focus, of course, is looking at chronic conditions, and we only treat urinary tract infections when they're symptomatic. As I work in communities, whether it be assisted living or long-term care facilities, the first thing that typically comes from a nurse is, I think they've got a urinary tract infection. Well, why do you say that? Well, they're confused. Well, my second question is, are they hydrated? So we never want to treat asymptomatic urinary bacteremia and treat only when those symptoms are present. Provide that advanced infection control training for your nursing staff so they understand all of these different reasons why we don't want to continue to treat. Because we have so many, many, many antibiotics that are no longer effective on some of our pathogens. But the first thing, avoid it for colds, influenza, RSV, and COVID-19. It's not going to help. It's not going to help viruses. So look at those look at those conditions. When should we avoid antibiotics? You can use supportive medications such as Tylenol for fevers, making sure they have adequate fluid and diet. Use clinical criteria based on advanced infection prevention practices and control practices to diagnose. Look at that. You've got McGear's criteria. Understand the different criteria that we'd want to identify when we're looking for pneumonia. And then provide symptom-based care. And I just mentioned that. Always use symptom-based care. How are we going to provide symptom-based care? Well, it's good care, supporting that individual, comfort related to maybe even Tylenol usage, encouraging fluids, making sure that we are very, very understanding that we have the right dose, the right duration, and the right drug. So a little bit of our history, I've been a nurse for a long time, and I remember that when we were discharging people from the hospital, we would put everybody on 14 days of antibiotics. So that's kind of not necessarily appropriate, but they're choosing the most narrow spectrum agents whenever possible at the shortest duration. In the community, the duration sometimes is 3 to 5 days. I've had physicians order an antibiotic for 10 days because the toe was red. Now, you as that professional nurse or those people in the healthcare field need to probably draw this back and say, do they really need that for a red toe? Maybe not. But use the most shortest effective duration, 3 to 5 days. You've got to look at their comorbidities and their medications and then drug-to-drug interactions, because that is one of those things that you're going to rely on your pharmacist to identify. Also give clear explanations. Again, anytime we go to the clinic, we don't feel very well, we do kind of want to come back with a prescription, I think. But if you give explanations and teach not only your clients that you're caring for, but your staff, the difference between viral and bacterial illnesses. By building these communication strategies, we're able to reduce that pressure to prescribe and then have positive outcomes. There should be some type of safety net or delayed prescriptions when appropriate. You're looking at that, and then educate on unnecessary antibiotics. We have that education available. We should be using it within our organizations and making sure that our physicians, we have a good rapport with the physicians or the providers within our healthcare system, that we talk about that risk of antibiotics and that risk of unnecessary antibiotics. And then look for simple solutions. What is simple? Well, some of the simple things that you can use are just things like checklists. Identifying, is this a respiratory infection? What is that standard assessment for that older adult? Pharmacy alerts for long durations of high-risk combinations of medications, and then follow-up calls. We need to follow up with our older adults that are in the community that we're caring for. If they're in our home care agencies or our group homes, do follow-up calls and find out how things are going. And then families. Well, families, you've got to engage families. Engage those families with some key messaging, making sure that they understand antibiotics are not harmless, even though the commercials after 7 o'clock in the evening talk about how harmless every single medication could be, but they're not necessarily harmless. We've got to systematically assess our infection prevention practices by using those standard tools, identifying gaps in our policies, our trainings, our day-to-day types of management, and then looking at strengthening outbreak response. The key is training people to identify, making sure you have advanced systems in place, quick identification, isolation of a, say, for instance, influenza immediately. Not, I think they had a cough on Friday and the infection control nurse is back on Monday. That's not how to work this type of prevention. You must make sure that we have good practices and policies in place and everyone understands them. Most older adults are, of course, viral or self-limited, and we also need to monitor for the number of prescriptions. But within this, our key goal is to message appropriately, identify accurate diagnosis, use the shortest and the safest course, and avoid antibiotics when not necessary. So with this, Tiffany is going to be talking about some training related to infection prevention practices for your staff. Tiffany?
Thank you. Let's go ahead and get started. Let's go to the next slide. Fostering a culture of safety, training to support staff implementation of infection prevention and control measures. Our number one goal when it comes to training is enhancing staff skills while improving the quality of care for clients and patients. We want to promote employee and client safety, comply with regulations, and attract and retain quality employees. Training provides employees with the skills they need to provide quality professional care. Employees who receive regular training are more likely to feel supported and engaged in their roles. They're also more likely to be more satisfied and comfortable with their position. Training plays a vital role in our industry. It makes sure employees are well equipped to provide top quality care. It helps employees feel supported and engaged in their roles. This can actually help reduce staff burnout and turnover. Employees who feel well prepared and supported in their roles can have lower levels of stress. And training can lead to improved satisfaction of clients and patients as they receive consistent quality care. The more knowledge, skills, and experience your team has, the higher likelihood for their productivity and effectiveness in the care they provide. Training also helps you set the culture of your organization. What you spend your time training on speaks volumes on who we are and what's important. Make sure you hit on why we're doing what we do, not just because they're protocols, but why this actually matters and the benefits to families, clients, and even our team. If we want to foster a culture of safety, then infection prevention and control has to be a building block of our training. We have to think about not only providing initial training to new hires, but also how will we provide training ongoing. As you create your training plan, make sure you have clear goals. The first of those is to make sure we include all compliance requirements, of course, looking at state and federal level, as well as CDC guidelines, especially as we're referring to infection control. You also want to communicate your training plan to your team and staff and make sure that you encourage communication and questions to be brought to your training lead. A training plan does not need to be difficult. Keep with the basics, they work. Good hand hygiene, cleaning and disinfecting measures, cough etiquette, utilizing PPE correctly. All of these topics can and do reduce risk of infections. So do not feel like you need to recreate the wheel. But one thing we do want to make sure we hit on is that infection prevention is a shared accountability. Everyone on the team is a piece of the puzzle in our efforts. In your training, use practical, real-world scenarios to help staff confidently apply infection control practices in their daily care. Then regularly look at your training plan and adjust, add, remove items as needed to ensure you are constantly hitting the goal on the training you're looking to provide. Do not be afraid to ask your employees for feedback, as this is how you can adjust and readjust your training curriculum to fully meet the needs of your staff. Ask, what items are we missing? Are there topics we spend too much time upon? Is the information presented in a digestible format? Feedback is key to building a program that's meaningful and successful and that everyone buys into. Strengthen your competency through coaching and observing. For example, many of us are already in the homes for reassessments and periodic supervisory visits. Make sure you're taking advantage of seeing your staff in action. Are they following protocols? If not, use this as a teachable moment. Provide on-the-spot training. Coach your team by example. Show them proper hand washing, for example. Utilize these times in the home for resupplying your team with the tools they need to be successful. Do they have appropriate PPE and spare supply? Do they have hand sanitizer, soap, cleaners? Make sure your team knows how to request additional supplies as needed, keeping the lines of communication open and encouraging them to reach out with concerns. Be available and respond promptly to training questions and concerns. This also shows your team that training and our protocols are important when you make their questions and concerns a priority. If you are working with other disciplines, work together. We are smarter together. We can create meaningful content that brings everyone together and on the same team. So with that, let's move to the next slide. Creating opportunities to enhance care outcomes. Let's talk about training with collaborative partners. We want to foster alignment by sharing core training with partners like home health, OT, PT, hospice, etc. Consider group training, joining forces and creating training that connects everyone together and encourages communication and collaboration. Use joint training to clarify roles, reduce duplication, and enhance communication. We are always using our training to help our staff be more efficient, provide them with a clear understanding of who is responsible for what role or process. How do we work together? How do we share what's going well? And how do we share concerns along the way? These are important questions to consider as we're working together. Leverage technology. Do not be afraid of venturing into the virtual world. E-learning can have huge benefits for your team. It allows training to be provided at your staff's fingertips and can be available to them 24 hours a day. Blended learning can also be beneficial when working with multiple teams. This takes the in-person training and virtual training, puts them together, presenting some topics in person while allowing other topics to be covered in a virtual element. Even after initial training is completed and things are running smoothly, still make sure you're having collaborative sessions. Bring everyone together ongoing for check-ins and aligning of goals. Promote a unified care approach. Let's work together. Let's keep communication going so that we reduce duplicate work and tasks, and we can also be more successful with what our goal is at hand. Let's go to the next slide. Let's talk about training in action. Let me share an example with you of an experience I had with one of our home care locations in creating a training plan that was heavily rooted in infection control measures, as well as collaborating with another discipline and how we were successful. We had an office who had an opportunity to work side by side with an assisted living facility, providing additional services to their residents. We were able to offer, at an additional cost to the clients who opted in, more one-on-one services than the assisted living was able to provide within their scope of care. This would help the assisted living keep the residents that needed additional care that the facility was not able to provide. The facility really wanted to make sure that this relationship was seamless. We needed to collaborate on needs, conditions, and overall goals of the community in general. The building also had a number of policies related to infection control that they strictly wanted followed due to having many high-risk residents in the facility. They wanted us to ensure that we would be sending staff in that were fully ready to work with clients and follow all of their protocols in general. What we decided to do here is to create a completely separate training plan for caregivers that would work in this particular building. We, of course, included all of our basic needs that any new hire would need to have training on, but in addition to that, we added a freshly created course that touched strictly on the infection control policies and measures that needed to be complied with within this building. We utilize a learning management system that has capabilities to create our own content, which comes in very handy when needing to meet training needs of any collaborative partners that we're working with. After creating this training plan, we presented it to the building and they were very pleased. We now have that training that is provided to anyone that will work in that building, and we've been able to now maintain this relationship for about 4 years. In addition to the training that we provide our staff, we also participate with the assisted living and their team regularly for training reminders, policy updates, and general collaboration activities. This keeps the relationship between the home care and assisted living teams strong and keeps us working as a team instead of two separate siloed teams. Remember, even in this situation, we stop, we take a look at the training plan for myself every 6 months to make sure that we are covering all important topics, adding in anything that should be included in the future. Remember, policies change, requirements change, recommendations change, and we need to constantly keep a pulse on if the training is meeting our needs. Colleen, I'm going to pass the group back to you.
Thank you so much, Tiffany, and thank you for that very comprehensive review of training and putting staff in action and safe care practices. We do have a couple minutes. If there's any questions, I would like we'll go to the Q&A and our moderator will take a review. Is there any questions that we have on the content?
We do have 2 questions. The first question, what strategies can senior leaders implement in nursing homes to promote hand washing among seniors, emphasize the significance of proper oral hygiene, and encourage healthy eating habits to enhance infection control?
That's a really good question. So I'm going to I'll take one of the things that we can do in long-term care as far as improving our overall infection control practices is to stress the importance of hand washing by consistently having our staff cue older adults. It's difficult. I've worked in long-term care for a number of years, and it's difficult to get individuals to wash their hands, correct? But we want to provide that opportunity. Going out, using the bathroom, let's wash your hands. Going to the dining room, let's get your hands washed. Providing areas, correct, Tiffany, so that they can actually wash their hands. Saying everybody should wash their hands without that cueing is not going to be effective. Now, you mentioned diet. Diet is an important element. And I know that for me, I was thinking when I turn 80, I'm going to eat whatever I want. It's not healthy. So trying to make good food choices and educate. I know that Tiffany, in your community-based services, I bet they have some type of session every week or every other week that talks about healthy habits.
Absolutely.
Yeah. So could you give them some responses as far as your training for the healthy habits that they provide, as far as diet or nutrition or?
Yeah, and kind of how you've talked about it, when everyone's doing things, right? We're all washing our hands. That everyone's doing these items, we're seeing it. So it's not something that is, foreign or something we haven't been doing. This is something that's just been kind of weaved into our day to day. And also, we are absolutely making sure that our caregivers are aware of healthy eating. What does that mean? What does that mean as we age and as our needs change? So we're also encouraging and putting together right ideas of what does healthy eating look like, what does being healthy look like, right? We're making sure we're brushing our teeth, we're washing our hands. So yes, it's all about getting the information out there and keep putting the information out there.
And the one thing I just want to bring forward, I know we're about out of time, but that brushing teeth. I suggest that in my world, I would like every older adult living in a nursing home to have an electric toothbrush. You can get them at one of the stores uptown, the big box stores, and they're electric and they're easy to hold, and they'll do that. But we have to have understand first, the staff needs to understand the importance, and then they have to reiterate that to the older adult and the importance of oral care. So it doesn't happen overnight, but it can become a cultural practice. Anything else?
I would love to see some go-to sites or resources that IPs can use often to help adjust policies per regulations.
So we provided here some helpful resources on and considerations. There are things such as your norovirus, your first line project, first line accessible infection control access. Those are helpful resources and provided by ComForCare that will assist you in your facility on reducing the rate of infection and, of course, the transmission.
There's another question. Are there available handouts for family members who want their loved ones tested for UTI anytime confusion is observed?
I'm going to give that to Tiffany.
And that might be something that we have to come back to
Yeah.
and provide the group an answer to.
Yeah. So there are training tools by the CDC for families, but we could probably come back to the group and send something out later.
Okay, we also have a few more questions, but we are out of time.
Mhm.
So we will send or make the answers available as part of the recording or a part of the attachment that's available with the recording in about 10 days.
Hey.
Thank you so much for attending.